good morning, good afternoon, and good evening to all the speakers, chairs, and the wonderful audiences in different parts of the world. The speaker for the first session today is our honorable guest from India, Professor Anita Jektia. Professor Jektia is the director and professor and head of neurosurgery at the Govind Bala Pan Hospital, New Delhi, India. She's also dual trained cerebrovascular surgeon, both in open and endovascular neurosurgery. She's an invited faculty to various workshops and conferences in India as well as abroad. She was the organizing secretary of the recent concluded Neurovascon conference in Delhi. She has several publications to her credit in the form of books, chapters, and peer-reviewed articles. We are extremely honored to have her today at our webinar, and today she'll be talking about freedom as a cerebrovascular interventionist. The speaker for second session of today is our honored guest from China, Professor Liu Guanbian. Professor Bian is the chairman and the professor of the Department of Neurosurgery, Rujin Hospital, Shanghai Jiao Tong University School of Medicine, Shanghai, China. He's also the director, Center of the Pituitary Disorder, and the director, Center of the Clinical Neuroanatomy. He's a noted surgeon who have the honor with several distinguished awards for his outstanding contribution in neurosurgery. We are extremely honored and grateful to him for accepting our invitation to speak at our webinar today, and he'll be talking about surgical management of Cushing disease. The chair for the session of today's webinar is our honorable faculty from India, Professor Partosh Pandey. Professor Pandey is the consultant at the Department of Neurosurgery, Manipal Hospital, Bangalore, India. He's also an important member of the Neurological Society of India and have held important position in the Board of Education of the NSI. He did his cerebrovascular and skull-based fellowship from the Stanford University and endovascular neurosurgery fellowship from the Wayne State University, Detroit, United States of America. His clinical interests are focused upon cerebrovascular, skull-based neurosurgery, infection, and neurotrauma. He has over 100 publications in various peer-reviewed journals and over 200 invited lectures at several conferences. We are extremely grateful to him for accepting our invitation to chair the session for today's webinar. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to welcome both the speaker and our chair and wonderful audiences to this online platform of the ACNS webinar. A warm welcome to our colleague in China, and we are extremely thankful to Professor Zubin for broadcasting this webinar on WeChat channel. Dr. Ben from Hong Kong and Dr. Joe from Malaysia are my co-hosts for today. I would like to hand over this online podium to our chair, Professor Pandey. Professor, please.
Thank you very much, Dr. Boone. And thank you, ACNS, for inviting us for this extremely important topic, which is very, very close to my heart. The speaker is none other than Dr. Anita Jektia, who is the director and head of Department of GB Pant Institute in New Delhi. This is one of the pioneer centers which started treating patients with cerebrovascular diseases with both open and endovascular means before it became a fashion after all these trials. Dr. Daljit Singh and Dr. Anita have been the pioneers in this in India, and the testimony to this is that large number of neurosurgery residents go there and do short-term and long-term training, which is very, very nice for the neurosurgical community of India. So thank you for that service, Dr. Anita. Anita is also a personal friend, and she's a great speaker. So we are all very excited to hear her lecture about the freedom that she gets of being dual-trained, hybrid, comprehensive, whichever word you want to pick it up, a neurosurgeon trained in both open and endovascular means. So without much ado, I'll hand over this to Dr. Anita, and she'll take us through her journey. Anita.
Yeah. Thank you, Pandey. Good evening. Nice to see you here. And I thank Dr. Raja, Dr. Boone, and all the ACNS webinar team to invite me for this webinar. And as Dr. Paritosh said that there are many terminologies which we can use for cerebrovascular interventionist, hybrid, comprehensive, that is all true. But with continued more and more centers involved in the training their residents for both the program, for both the modes of treatment in cerebrovascular surgery. Maybe in a decade's time, there'll be no conflict saying that what type of treatment. It will be a routine, the way we do all surgeries like spine surgery, endoscopic, MIS, open, pituitary or skull-based surgery, any skull-based surgery, endoscopic or open. So what I think that within a decade's time, this will happen with the cerebrovascular surgery, that it will be only cerebrovascular surgery, nothing endovascular, catheter-based or open surgery. So without wasting the time, I would like to go through all the cases which we have been performing or which we have done, which say that a cerebrovascular surgeon is not only open surgeon or not only the catheter-based surgeon. It has to be. It requires a holistic treatment of all cerebrovascular surgeries, and you would know that how knowing all modes of treatment, it makes your skills better. It gives you full freedom to treat a person. Next slide. Yeah. So is this visible and am I audible, Paritosh?
Yes, you're audible.
Yeah. So cerebrovascular interventionist means what I feel that it includes both open surgery, that may be direct surgery, or indirect surgery. Indirect surgery means any anastomosis and all. And the other method is catheter-based surgeries. So there have been papers, there have been publications which say that there have been very many advances in the catheter-based surgeries, many coils, many wires, many catheters. And because of these advancements in technology, the endovascular approaches to many cerebrovascular diseases has improved. And at the same time, the senior authors, they are also feeling that because of the involvement of endovascular catheter-based surgeries in the cerebrovascular intervention, they are getting less number of the cases because majority of cases are being treated by the catheter-based surgeries. So if you see this article, this was a study which was done in children. And what we are seeing, we used to say that, okay, the anterior circulation aneurysms like MC aneurysm, EC aneurysm, they are not good for the catheter-based surgeries. But now we are seeing many papers like this, where the children, and that too anterior circulation aneurysm, they are being treated by stent with coils or even with FT. And the results are not so encouraging, considering being the neurosurgeon, that 80% showed progressive occlusion, not instant occlusion. And 20% there was no change, and one patient who had FD, there was occlusion of the FD, however it was asymptomatic. So if we are not trained as a holistic cerebrovascular surgeon, we would be getting these kind of results where we will see the stent-based complications in the children, and using the stents in the children with all kinds of added drugs which are required for the stent placement. So, and at the same time, we see more number of publications on endovascular management, and perhaps this is because the open surgery that is proved, and the catheter-based surgery is in the phase of proving itself. And one need to understand that both the treatments, they have strengths and weaknesses, and they are not competitive. They make they are complementary to each other. So if someone says that catheter-based surgery is minimal invasive, I totally disagree. You have so many catheters, long catheter, short catheter, sheaths, then distal access catheters, one-sided groin puncture, other side groin puncture, and not only the groin, you're taking the catheter, you're taking all the gadgets, all the hardware right from the groin or the radial or the brachial or direct carotid punctures to the brain. It cannot be so minimally invasive surgery. If you see so many catheters, so many wires going from groin to the brain, it is not at all minimal invasive surgery. So, but if I say that since catheter-based surgery is not minimal invasive surgery, so I am going to be only the microneurosurgeon. That is also not correct, because if I'm a hardcore microneurosurgeon, I lose the microsurgical skills again, because more and more people are going for the catheter-based surgery, and we have to accept that catheter-based surgery is less, it requires less training, and it is easier to learn for the current generation who are very much gadget savvy. So I need to do the balance for both the procedures, both the management options. So why do I need to know, other than this, that it is the patient's demand? And we can't deny in this time that every surgery can be performed by the open way, or every surgery can be performed only by the catheter. And it helps you, when you do both the procedures together, it helps you understand anatomy better, and you have many options available, and this enhances again your skills. So just going through all the examples, majority related to the brain, brain aneurysms and AVMs, because it's a vast topic. It's difficult to cover all the aspects, but trying to do maximum possible. So if you see, this was a lady, young lady, who came to us with in a poor grade SVH. And she had hydrocephalus along with the CT showing SH, and she was referred to us, and with the conservative treatment, because this was posterior circulation aneurysm, she was put on external ventricular drain, and over the time she improved neurologically. And when it did the DSA, this was the digital DSA of this is vertebral angiogram, which is showing the aneurysm somewhere VA and some branch arising at the junction, and there are multiple aneurysm, one here, and there is one small arteriovenous communication. But since it was not very clear from where it is arising, we took the ICA shoot. This is super selective ICA shoot, which is showing this aneurysm is not at the junction of VA and ICA. This aneurysm was actually in the distal part, post-meatal part of the ICA. One aneurysm here, another here. One more, if you see, this is fusiform dilatation here, and there is one small arteriovenous nidus communication. So we thought that since it is posterior circulation, I thought that we can go ahead with the endovascular, the catheter treatment, but we could reach only up to this level. With the best Duos catheter, I mean, in fact, Duos the microvention catheter. So we could achieve only this much occlusion. Just a minute. Yeah, we could achieve only this much occlusion, and our catheter, we could not renegotiate the catheter beyond this. And if you see, there are very few articles on the ICA aneurysms. So if you see the anatomy of the ICA, the ICA has got two parts, the premeatal segment and the postmeatal segment. So this is the part which is premeatal. This is the part which is premeatal, right? This is the 7th, 8th now. So this much part is premeatal. If you see, this much part is premeatal. These premeatal ICA aneurysms, they are difficult to treat, whereas the postmeatal ICA aneurysms, which overlie the cerebellum or the lateral medullary cistern, they are easier to clip. And it is something like any other posterior fossa surgery. And if you see the CT angio, the aneurysm must be lying somewhere in the medullary cistern, and that is what we found intraoperatively. There was one fusiform aneurysm on the surface, other aneurysm buried in the cerebellar surface, and this could be easily clipped. The other aneurysms, which was coiled, we could also locate that, opened it, clipped it, and removed the coil. So if you see that this selective angiogram was so important to understand the anatomy, the location of all these aneurysms, and this is pre-operative and this post-operative with good outcome, and this patient was discharged. So any aneurysm, if you say that it is posterior circulation in poor grade, it should be treated because you may get good result as well. This was another case again. He presented to us with this kind of CT, infarct, grade 4 again aneurysm, and this was pica. This was also opened and clipped. This case was done when there was breakdown of the machine. So this, you may have your technology may fail also during your procedures or during your planning. So you have to know both the kind of procedures that you can, in case required, you can open up and do manage the case. This was a case where posterior circulation aneurysm, white neck, you can see both the PCAs arising from here, white neck. So we did the neck stent assisted coiling and got the good results. There are many cases of posterior circulation aneurysms where the endovascular treatment is, catheter-based treatment is very straightforward. It is easier to negotiate and reach to the target site, and you can occlude and get very good result. Especially the dissecting aneurysms. There are two ways of managing. Many open surgeons only, they do this bypass and occlude this. And if you see, but if you see the super selective angiogram, you see that these dissecting aneurysm arteries, the arteries which are involved in the dissection, they're usually their terminal arteries, the distal ones, not the proximal ones, and you can occlude them without doing major skull-based surgeries. If you see the other aspect of cerebrovascular anatomy, normally it is taught that the part of the ICA which is paracellular, they are cavernous segment ICA, but actually it is not the case. If you see the carotid cavernous fistula can happen to occur from the petrous segment of ICA up to the anteroclinoid process. Anywhere along this part of the ICA, there can be communication with the cavernous sinus. So cavernous sinus extends right from the petrolingual ligament up to the anterior carotid and anteroclinoid process. So if you see the cavernous sinus, these are the few examples of carotid cavernous fistula, where the cavernous sinus may drain anteriorly into the facial vein, into the orbital vein, angular vein, and the facial vein. Then posteriorly, it may drain into the clival and meningeal veins, and medially pituitary, venous plexus, and they can be even drainage into the uncal vein or the superficial middle cerebral vein. So depending upon these venous drainages, there can be manifestations of cavernous carotid fistula. So why this happens? Why few patients, they have drainage into the interior aspect, that is ophthalmic, posterior or petrosal, or the petrosal, or the clival plexus, or the osseous. Why it is so variable? So if you see the anatomy of the cavernous sinus, and many a times you also find that when you are operating, sometimes the cavernous sinuses, they bleed profusely. Sometimes the cavernous sinus is so silent that you can manage the bleeding very, very easily. Histologically, the trabeculations of the cavernous sinus, they may vary. They may be dense, they may be few. If they are dense, then of course the bleeding will be less. And if they are few, then they may bleed more. If there are few trabeculations, there can be many communications with the venous channels. So this all depends upon the anatomy of the cavernous sinuses and the adipose and the connective tissue into it. So if you see this kind of cavernous, this kind of CCF, so here the petrosal part, it is the communication is in the part of the petrosal segment of the ICA with the cavernous sinus. So it's not that the CCF will happen only in the paracellular area. It can have the communication in the petrous part of the internal carotid artery. And usually we used to do a decade ago, we used to do this kind of cases with a balloon and used to get the good occlusion, good postoperative result. If you see one more this case, there is a communication between the horizontal segment of the internal carotid artery, and we did transarterial occlusion of the fistula. Another case where there is communication in the sellar segment, and this is preoperative, and this is post-operative result where the chemosis and or ocular signs are they got disappear. Then we have heard many times is intercavernous sinus. So this is how the intercavernous sinus is. This was a case where the ocular symptoms were on this side, whereas the filling of this side communication was from the contralateral internal carotid artery. And if you occlude the intercavernous sinus, this can be treated. So idea of showing that how it makes you anatomically wiser and anatomically you get more detailed anatomical knowledge. This is another case of cavernous sinus. This is huge cavernous sinus, and if you see, this is intercavernous, and the other side of the cavernous sinus is good trabeculated. It is not so densely packed with a connective tissue. So this could also be treated with a transarterial occlusion. This is another case of carotid cavernous fistula, low flowing, where there is, if you see this, this is meningohypophyseal artery of the, and this communication between the branch of the meningohypophyseal, between the branch and the cavernous sinus. So these are the cases where we get to see this kind of anatomy when we are doing pituitary surgeries, the multi-compartmental pituitary extension, pituitary going into the cavernous sinus. You may find this kind of anatomy, that petrous anatomy you may see. You may see the different segment of the carotid artery along with the meningohypophyseal. So if you are doing catheter-based studies or the managements, your knowledge is enhanced. Like you can see this, you can imagine this, you can visualize this in the 3D anatomy plane, that all these things can be seen during your surgery. Otherwise, majority of time you are seeing these cases only with the tumors and all, where you don't get to see these arteries. But when you're doing catheter angiograms, you get to see and get to know all this. And this was, again, the catheter was negotiated into the fistulous communication coil, and this is post-operative, the ophthalmic vein is not filling up. Another girl who had communication with the branch, with the external carotid artery and the Vidian artery. This is Vidian artery. So Vidian artery is communication with the external carotid, and this was draining into the ophthalmic. This was, since it was difficult to negotiate this artery, so we placed the flow diverter, and you can see this artery is not visible now, and the flow in the ophthalmic is also their hemodynamic changes has happened. Another case of petrous segment communication with the cavernous sinus, and you see these kind of cases can be, nowadays they are managed through the transvenous route, but this case was, since it was in the almost the straight segment of the carotid artery, we obliterated this communication with a covered stent, and this covered stent in India of Abbott cost only 9,000 rupees, and but these are the cases which can be treated best with a covered stent. They should be actually in the straight segment of the petrous ICA. If you see the cavernous sinus aneurysms, the majority are being treated by FD, but if you do put the covered stent, this is covered stent what you are seeing, and you have to inflate it with a balloon, and when after balloon inflation, this is pre-operative, and here is the post-operative. You can see just by covering with a normal stent, and you can achieve the best result, and you can understand the anatomy better. How important was this artery? This artery, the same artery which was in which there was communication with the sinus in the sinus. This whole artery was supplying the whole brain, both ACA, both cerebral territory, and as well as the PCA, and going retrogradely into the basilar artery. So actually it teaches you the physiology of the brain as well, cerebral circulation. Another case of CCF, which was again occluded few years back with the coils, but there was recurrence, and this was also treated by the graft master Abbott, covered stent, and this is after the surgery. You get to see very good results for CCF by catheter-based surgeries, and like you see the orbital signs, pre-operative orbital, post-operative, the disappearance of chemosis and proptosis, pre-operative again, and this is post-operative, almost cure. But we need to know that all fistulous communications are not good, and they are not benign as well. They can be very, very dangerous and fatal communications also when there is communication with a CVR, that is cerebral venous drainage is there. This is the whole cranial drainage, and these are the cases which can be fatal, and you may land up losing these cases if they are not treated properly, as was in this case as well. If you see that being the surgeon, we always talk about AVM, and that too in terms of Spezla-Martin grade, that this is the size, this is the eloquence, this is the drainage. But that is not sufficient. That ideally is not sufficient when you see into this classification which was suggested by Yasargir and Valvanis, that not only the size and the drainage, there are many things which are important when we are managing the AVMs. Like they can be convexity, they can be superficial, they can be deep, they can be only in sulcal, they can be cortical, they can be sulcocortical, they can be ventricular, they can be only in gyrus, or they can be sulcogyral. So which are sulcogyral, they are diffuse. Then they can be deep. Deep can be again subarachnoid, parenchymal. So these are the various anatomical locations of AVM. They are equally important to understand and know that not only the size or the location. Then based upon the feeding arteries, they can be multiple feeders, single feeders, they can be terminal AVM, they can be pseudo-terminal AVM. So, and they can be even leptomeningeal as a supplementary feeders. So you need to understand the whole lot of anatomy when you are going to treat the AVMs, and this helps you in understanding the anatomy, the management part, and the physiology as well. So if you see, this is a selective angiogram, and this is the nidus, and we are seeing that this nidus is not supplying any other part of the brain. So this is a terminal feeder. If you see this super selective shoot, then here is the AVM, but at the same time it is supplying the normal brain. So this is a pseudo-terminal or the indirect feeder. So if these are the cases, if they are completely occluded without thinking that this is supplying the normal brain as well, they can be fatal post-operatively, both in terms of the catheter surgery or the open surgery. So if you see, this is terminal nidus again this is one more terminal nidus. So if you see these kind of niduses, there you can sacrifice, or you can go into the feeder and completely occlude the nidus. This is again super selective. And if you know that, knowing this all anatomy, that the feeder can be diffuse, feeder can be multiple, feeder can be pseudo-terminal as well. They can be gyral sulcal or gyrosulcal. Besides knowing the eloquence, non-eloquence, you can do this, that there is no need to remove the whole this part. You can spare some part which is pseudo-terminal feeder, and this way you can avoid giving more post-operative deficit. Like this case, this is a diffuse feeder, and here if you see, this is supplying some of the area of the normal brain is also being supplied by this. But leaving this part, you can give good outcome, and post-operative angiogram also shows good result. Another case, multiple feeders. If you see, one feeder from MC of the contralateral side, then AC of the other side. Here is the terminal feeder, which is again pseudo-terminal. Then the same patient, you may find multiple weak points and in the venous on the venous side. And when you start embolizing, you may be able to embolize in one go, you may not be. This case was treated in stages. And when you appreciate, when you see this angiogram and you compare this angiogram, you see how the dynamics is also changing intraoperatively on table. That this is the carotid of the left side. This is carotid angiogram. If you see this carotid, the dimension of this carotid and this carotid, here when this is gone, you can see the whole artery. At the same time, you can see that this artery is supplying the other side, opposite side also, which is not, there was steel because of this AVM, patent AVM here. So what you see, you are seeing the change in the dynamics, change in the caliber of the artery, change in the territory supply by the artery. And if you see, the MCA flow is also better after embolizations. So not only anatomy, you understand the physiology better when you are performing. You're a holistic cerebrovascular surgeon, and we need to accept that only going for the clipping will not make very good cerebrovascular surgeon in the future, because catheter-based surgery is definitely the less time, like it takes lesser time to learn and to acquire the skill compared to the open. if we are not teaching our next generation both the types of surgeries, both the types of managements, we are going to get this kind of operated cases to us where the hematoma is removed just by a big huge bone, big huge scalp flap, and the angiogram showed in this case IC aneurysm and MCSM, which is a very easy surgery for any cerebrovascular surgeon or any neurosurgeon, where they can both be clipped. So it is essential to teach and learn both kinds of treatment, where you are not going to get very big scalp flaps. You are not going to deal with a big scalp flap complications, which is more painful than treating the aneurysm itself. This same aneurysm can be clipped in the same sitting, one ICA and the MCA bifurcation aneurysm. When you know the anatomy, you can translate the same anatomy in the catheter-based surgery. When you are seeing so many perforators attached to the sac, when you see this angiographically, you will say so many vessels are arising from the sac. But actually, truly, it is not the case. These perforators, they can be dissected off and the neck can be reconstructed. These perforators, what are visible, they can be dissected off the sac, and you can get the good reconstruction of the neck of the aneurysm. If you see these perforators, normally we say that majority of perforators, they arise from the posterior superior aspect of the anterior communicating artery. But when there's hypoplastic opposite side of the circulation, they may arise anywhere from any wall. Like in this case, the big vessels, they are arising from the inferior aspect of the anterior communicating artery. So if you know all these anatomies, you can translate microsurgical anatomy into the endovascular and the catheter anatomy into the microsurgical procedures. Majority of us in India see this kind of vessels during the aneurysm surgery, the so big plaques, and probably these plaques may be the big cause when you are doing the catheter-based surgery and the complications associated like ischemia and embolic complications. So this is the reason you give the heparin, your catheter or the wire is bent, especially the microwire is bent, so that you do not hit these lesions intra-arterially into the wall. And whereas you see this kind of anatomy when you open the case, but you don't see this all when you're doing the catheter-based surgery. So one need to know both aspects, that what all lumen changes can be there in different age groups. Of course, if you are a cerebrovascular interventionist, I would say, then you can avoid radiation to the pregnant patients with this huge aneurysm, and you can clip and gain good result. Another 3-year-old child who presented to us with this big huge hematoma in the interhemispheric fissure, and there was distal anti-communicating artery aneurysm, and which was clipped, and just like any other transcallosal approach, you can treat them. Another child who was actually accidentally given incision, thinking that there was a swelling like cold abscess in the region of the mandible, and there was torrential profuse bleeding, and angiogram showed this dissecting aneurysm of internal carotid artery. The whole artery got dissected and there was no distal flow beyond this. So we just occluded with few drops of NBCA, and this is the post-operative after removing the bandage. This was healed. Now there was a lady, 60-year-old female, and who had hypophyseal segment aneurysm. These are the cases which cannot be dealt just by coiling or by the simple stents. They really need FT or FT along with a few coils maybe to get the best result. But if your patient is not able to afford, you can't say no to any patient that we can't do because we don't have gadgets. So, or you can't afford this treatment, because in India there is no insurance, there is no universal insurance. So we need to justify to all the patients that we can give, we have to give the treatment to all. So you can clip them and get the good result. FD of course requires prolonged follow-up. So you should be able to see the follow-up, you should be able to follow these patients, how your treatments are showing the results. This is another case where preoperatively he had proptosis. At the same time, he had 2 pseudoaneurysms in the neck, post-traumatic, and you can deal with these aneurysms in the same these 2 pathologies in the same sitting, that is CCF and pseudo CCF as well as pseudoaneurysms. Another case, when you are doing pituitary, you may injure the internal carotid artery. That is what we also did in this young lady, and she had this aneurysm. But if you see there, the coil mass is very big. Finally, this is dissection. Actually, it is not aneurysm, it is dissection of the wall, which has led to the flow of blood into the cavity. So these are the cases which cannot be treated only by the coils. This requires the vessel healing actually, and that can only be done by the FT. So this was finally treated by the placing the stent across the rent. So this is another case of giant anti-communicating artery aneurysms, and they are best treated. What is appearing here is actually not translating intraoperatively. This is such a huge and giant thrombosed, partly thrombosed aneurysm, and which can be best managed by the clip-in and excision of the sac, which is very routine surgery for any neurosurgeon, where they routinely deal with this area pathologies like craniopharyngiomas and other meningiomas. This is post-operatively opened and reconstructed. Many a times in this era, when you're doing both catheter and open surgeries, many times your tray is not having exactly what clip you are requiring to treat some case. Similarly, it can happen for the aneurysms also, that what coil you are looking for, you may not find that size of the coil. These cases can be dealt with dual catheter, 1 catheter, 2 catheter. You can treat them by using dual catheter and coil them and occlude them. So this is another case of young patient, and if you see this superior hypophyseal artery aneurysm, this is the aneurysm. This patient, the ideal treatment was FT, of course, if you want to do the catheter-based surgery, not the other standard stents. And this was treated by, if I have time, I can show a short video of opening the idea of showing is that it's not that if you're doing only catheter based surgery, you cannot operate any case which is requiring the skull based surgeries, more invasive skull based surgeries like drilling the ACP, or it's not moving forward. I think because of shortage of time, I can just show that after drilling and opening the falciform ligament, drilling of ACP, opening the rings, this is the aneurysm, you can clip the aneurysm also. You should have that freedom also, not only the catheter. You should be able to do the skull-based surgeries for the complex aneurysms with a good results. This is another case of young man who presented with this diffuse SAH. If you see this as a neurosurgeon, I'll read this as a blister from the medial wall of the ICA. But when you see the angiogram, you see this whole segment is diseased. It is not only this is the aneurysm, this whole segment is diseased. And if you see this is disease, at the same time there is spasm. So segment, not only this segment is diseased, the segment which is diseased is from here to here. This much segment is diseased. So these are the cases where the wall healing is required. It is not the simple aneurysm. It is the sorry, it's not running. the FD was placed, and now if you see, the wall is so nicely healed. What abnormal wall you are seeing, this is more or less normalized after putting the FD. So this is making you understand the anatomy, the physiology as well, and what mode of management is best for which case. This is another case of CCF, where this was a young lady and who had road traffic accident. This is the angiogram. Why it is not running? Not able to run the films here.
Professor Anita, maybe you can exit the presentation mode and see if it can play in your PowerPoint.
Okay. End show, right?
But you need to share the screen with us.
Okay, okay. Yeah, is it visible now?
Yes, it's visible.
Yeah.
Yes.
So is this fine?
Yes, we can see the.
Yeah.
Yeah,
So,
maybe after the video.
Yeah. Is it fine now?
Yeah, we can see
Yeah.
the.
So as a neurosurgeon, what would you say? Actually, when we did the angiogram, I thought it is middle cerebral artery. This was a selective shoot of internal carotid artery, and I thought it is middle. It is MCA, and when we took the catheter, microcatheter across this we reached first into the cavernous sinus and reached up to the superficial middle cerebral vein. Actually, this was not MCA, this was superficial middle cerebral vein. And on subsequently coiling this fistulous communication, now we could see the middle cerebral artery. So idea of showing is that there can be drainage, as previously said, that there can be drainage into the superficial middle cerebral vein. So through the arterial route, you can go into the cavernous sinus, then you can go into the superficial middle cerebral venous site of the fistulous communication and occlude these communications. So this is how you make your anatomical knowledge is strengthened by doing both surgeries, both catheter-based angiographic surgeries and the open surgeries. So if you see now, the whole stele is gone. The communication between the superficial, the drainage of cavernous sinus into the superficial, communication between the superficial middle cerebral vein and the cavernous sinus, that is blocked, and the stele is disappeared. And you can see good MCA territory filling up with the internal carotid artery. And this is post-operative, not added deficit given when the cavernous sinus was filled with a coil with packed. So it's not that all the time transvenous route is only viable option. You can go and do the transarterial occlusion as well. This was another case of and this was a 52-year-old man who had very bad chest. In the morning, the anesthetist says, you can't do, it's difficult to take the patient for surgery, going to be relatively longer surgery when we do the craniotomy. And this was the PCOM aneurysm. Okay, let's go ahead coiling. So if you had the bad chest and some medical problems with the patient, you can go with the coiling of these small aneurysms and can get good results. Another case of a young girl who had intraventricular bleed, and this was the CT angiogram, which showed that there is some nidus and some venous channels. But when we did the angiogram, this was the angiogram, internal carotid shoot. There are multiple channels and this is ultimately draining into the deep venous system. And if you see, this is the MCA filling up and it is draining into the deep venous system. When we did the superselective shoot, we see this is the artery, this is the vein, and these all are venous pouches. You're not seeing nidus, but there is direct communication between the artery and the vein with many venous channels. This is the venous pouch, and beyond this, these are the dilated venous channels. And onyx embolization actually made this anatomy better, that this all onyx spill is there into the communication. And if you see this is gone. This small abnormal communication is still left. And in AP view, if you see this is the part which is left. It was not wise to occlude this part because the anatomy, what we thought initially that there is some big nidus, but actually there were abnormal venous communications between the artery and the vein, and these are the patients which should be followed up for the next if they actually require any treatment. So actually, if you are performing both surgeries, it definitely enhances your anatomical knowledge, your skills, and every country has good scope for all. Like for all means anybody who is trained in all kind of management, means open or the catheter-based surgery, they all can give comprehensive treatment of cerebrovascular surgery. And catheter-based and open surgeries, they are not competitors, they are complementary. And to get the best result, it is essential that one need to understand that both the treatments are essential, and to call yourself as a cerebrovascular interventionist, you need to learn both modes of treatment. This is our team, Dr. Daljeet and whole lot of staff. As Dr. Paritosh said that many observers, many trainees are coming to our institution. And of course, it is not one-man show. Catheter-based surgery and any cerebrovascular surgery require many hands, and this is all our department. And thank you again, Dr. Raja, Dr. Paritosh, and whole ACNS team for inviting me. Thank you. Thanks a lot.
Thank you for this very, very elaborate lecture on the necessity of any future cerebrovascular surgeon who is serious about his business to be conversant in both techniques. And being that for a fairly long period of time now, I really think that initially when I was only a microsurgical person, cerebrovascular surgery for me was just aneurysms, clip aneurysms all the time, And when you do this, you are opened up to so many other things that aneurysm just becomes very, very secondary of things like stroke, dural fistula, CCF, spinal vascular malformations, all kinds of things which Dr. Anita so eloquently told in this. Yeah, if anybody has any other questions, I think we are welcome to have questions, and let's ask them. Anybody, they can raise hands and have questions.
Yeah, can I ask 2 questions, Professor?
Sure.
Yeah, thanks, Professor Anita, for very comprehensive lecture. I have 2 questions. I'm just an open neurosurgeon, and we're relying heavily on 3D imaging for us to understand the architecture of the aneurysm and also the vessels. Therefore, we actually heavily relying on the CTA. And as an endovascular surgeon, you show us all 2D DSA So what make, is there any differences between these two images in your practice? My second question, Professor, in ruptured aneurysm, if a person needed a stent-assisted procedure, usually a patient need to be started on a dual antiplatelet, and there will be a delay about 4 to 5 days before an intervention can be carried out. And as an open neurosurgeon, we usually try to intervene as long as the brain can accept within the 72 hours. Would you think that by delaying the procedure for endovascular is a compromise for the patient? Thank you, Professor.
Yeah, yeah, thank you for the good questions. Yeah, first I'll answer the second question. Nowadays, you're not keeping the patient for 5 days or anticoagulants and then waiting for that and taking the patient. You can always do on-table anticoagulation, and during the procedure, just before, while performing the catheter angiogram, actually, you can always load the patients with anticoagulants. That is no more contraindicated. No more the delay surgery is no more done. You can do it on the day of the surgery. Everything can be done. The anticoagulants can be given on table. Another question is, of course, what I showed, because we had the lab which was 2D lab, we didn't have 3D lab. So we take all three views, both AP, lateral, oblique, and different views, different angles we take, and we create the anatomy that, okay, where are the branches, where is the sac, what is the anatomy, what is the venous outflow, what is the arterial flow. So in different views you take, and then you imagine what you construct your own 3D, that what all is the angio-architecture of the case. Yeah, of course, nowadays you have 3D labs and all. They are, of course, definitely better. I agree with you.
Thank you for your answer, Professor Anupam. Yeah, Ben, your question?
Yes, Professor Anita, thank you so much and congratulations on the results of your team and make an endovascular team in your center. I would like to ask about your experience in using the cover stent for the intracranial ICA. So how would you, because usually for the stent property, one would consider using the flow diverter instead of the cover stent. Do you find any there, and is there any difficulty when you deploy the cover stent? And also whether there possibility of, for example, some TIAs or other events after the deployment of the intracranial cover stent? And also the antiplatelet regime for the cover stent, is it the same as the flow diverter? Thank you, Professor Anita.
Yeah, thank you, Ben, for the question. Actually, you're right that covered stents has their limitations. We are not using for the covered stents beyond the petrous ICA, because petrous or the horizontal segment, which is relatively straighter segment, covered stents are heavier stents, so you can't take them beyond that. So if you are having any pathology in the cervical ICA where there is no branch, or the petrous where there is only meningohypophyseal is arising, or horizontal, just maybe small straight segment, you can take right up to their place only, not beyond that. Second thing is that it is different from the FD. It is PTFE covering is there. What is actually indicated for the peripheral vascular surgery? It is the same stent. So again, the length is also a limitation. The diameter is also a limitation. So you can put these stents only up to 5.5 millimeters arteries, and say about 20 centimeters is the length. So that is the limitation for the covered stent. We are using covered stent mainly for the CCS, and that too when the communication is in the segment of the petrous ICA, the straight segment.
So the antiplatelet regime is the same for the cover stent?
No, it's different. It is for FD, that is again the what you use for the any intracranial stents, and it is PTFE coated stents, the covered stents are.
I'll ask you a question, Anita.
Yeah.
What do you think is a good training module for a neurosurgeon who wants to train themselves in cerebrovascular interventions?
Yeah, Paritosh, you are well trained and you know, I think you are, you know, better than me the answer. But actually, look, we were very fortunate, as you said, Dr. Dalji, Dr. A.K. Singh and all. And when I was doing residency, I got exposure for both. For me, there was nothing like catheter or non-catheter. For me, it was like this case requires best, you need to know the anatomy best. And you are not getting the anatomy by 3D, by CT angio. You have to go undergo the VSA, right? So this is the case where I would be requiring more of the skull-based work. The outcome may not be so good, and you can get the better outcome with a catheter. So go ahead with this. So for anywhere where you want to start both the program, the faculty should get trained first. The faculty in that institution that get trained first, they should undergo the training, and they should be open to accept both the treatments.
Right.
That is very essential. It's not that you're doing bypass and justifying bypass for any fistulous communications when you have the catheter-based surgeries. So that needs to be, that open-mindedness, that is very essential. And that is the best way of learning and treating, that when you are doing the residency, that is the best time, when you have freedom for both the modalities. Otherwise, then only you are open for both the treatments, actually. Otherwise, you get biased.
Absolutely. Anyone else has a question? Or else I'll hand over the mic. Thank you, Dr. Anita, for this fantastic lecture. And may you train many more neurosurgeons for these cerebrovascular interventions, and may you keep your doors open for all the neurosurgery residents who want to come and learn these techniques. Thank you very much.
Thank you, Pandit. Thank you, Paritosh. Thanks a lot. Thanks, ACNS.
Thank you, Professor. Now we may move on to the second lecture by Professor Bian. Professor, you on?
Yes.
Yes, thank you, Professor.
Yeah. Okay, I will share my screen. Thanks. I was invited to share our experience of the surgical treatment of the Cushing disease. Now I will introduce the surgical treatment of Cushing disease of our center, 507 cases. Now we will special thanks our endocrinologist of the Professor Zhou, Su, Wang, and Ning. All these cases was supported by the endocrinologist. Okay, as we know, the Cushing disease was first described by Harvey Cushing in 1932. The incidence was 1 million per 10, usually in the adults, but really in children, just only occupied 5%. Most Cushing syndrome caused by the pituitary. Now we caused the Cushing disease, and usually not real caused by the main one, and the mostly was a woman, and male predominance in probable patients. So as we know, if the patient untreated of the controlled hypocortisonism, and their death rate nearly 50%, may be caused by the serious infection, cerebrovascular accident, and others. So if we know that Cushing disease or the Cushing syndrome have the special symptoms and signs, including metabolic, such as the central obesity, weight gain, hypoglycemia, and dyslipidemia and hypercalcemia. And the second is the hormonal, such as the menstrual irregular or amenorrhea or delayed puberty. And the third, the musculoskeletal and cardiovascular and dermatological and neuropsychological and immunology. So the Cushing syndrome and affect all the such as the can affect the the patient. So Cushing disease have a typical syndrome and signs such as the Cushing and gait weight and central obesity, hair weariness, and strut, and especially we should to sometimes maybe to concern about neuropsychological syndromes. It's very important for us to pay more attention. So if a patient with a syndrome or the signs of the Cushing disease, we should to 3 questions should to answered. First, the hypercortisolism, whether or not. So this time we should to measure ACTH level, serum cortisol, and the 24 hours urine free cortisol. And the second, we should to answer source of the hypercortisol. So this time we should to do low dose or high dose dexamethasone suppress test. So if the low dose suppress test is negative, maybe it's ectopic or adrenal. If the low dose dexamethasone suppress test is the negative and the hypodexamethasone suppress test is the positive, maybe indicated the pituitary. And the third question we should to answer, where the location of the hypercortisone, including the pituitary, we should to do MRI scan and the adrenal CT scan, and sometimes we should to do petrosal sinus symptom. And then the second question, maybe the ectopic, we should to do CT scan such as the chest abdominal and the PET CT of the whole body. And then the third, maybe adrenal. So we should to do give the patient to do the CT scan and maybe other patient. So all these cause of the Cushing syndrome, we should to do low dose or high dose, and the image scan, and sometimes maybe to do the petrosal sinus sampling. So sometimes the differentiate the diagnosis is very difficult. So in our hospital, it's a pathway for the Cushing disease. So first, if the patient have the signs and the symptoms of the Cushing syndrome, and go to the endocrinology department to evaluation, and then including the low dose, high dose, MRI scan and bypass and adrenal et al. If the patient diagnosis as the Cushing disease, this patient can transfer to our department. And we, according to the intraoperative finding, pathology, and the results of the after the operation, and then this patient to have a long-time follow-up. Now, we will report our data from 2003 January to 2022 December, or we have the 570 cases, 73 cases, but we in 2006 we have the bypass, BIPSS. So now we will report for from the 2006. Now it's our case, all the cases from Department of the Endocrinology, including the female and the male, and it is the age. So all these cases, we have the serum-free cortisone and the rhythm disappear of the cortisone, and the 24 hours, the urine cortisone and ACTH level. During these cases, we have the 237, the ACTH level is normal, and 270, the ACTH level is elevated. And then this patient have to do the high dose dexamethasone suppressed. During all these cases, we have the positive. It's 422. The negative is 85%. And then this patient to do the cellular MRI scan with the enhancement, all these such as the large giant a tumor and a larger tumor, and it's a micro, and also it's a negative. So all these cases, we have the 122, the MRI scan cannot find the tumor. We diagnose it, we cause these cases the negative. So when the patient, the cellular MRI scan cannot to find the tumor, and sometimes maybe high dose dexamethasone suppressed test, the ambulance we caused. Okay, yeah, later I will to answer the question. Yeah, and if the high dose dexamethasone suppressed test, it's not real or the 50%, and we should go with the patient to do the bilateral petrol sinus sampling. All these cases, we have the 482, and the positive did nearly 90%. Now, to our department, when all these cases transfer to our department, how we can to treat this patient according to the before operation, the MRI scan, and the BIPSS. So first, if the patient MRI scan can find a tumor, we should to remove the tumor and the peritumor, and also a pseudo capsular to resect the tumor, such as the cases, it's 80%, 80 years just the weight gain and stride 2 years, and blood suppress also, and ACTH level increase, and urine increase. Also, we can see the MRI scan can find it's a tumor on the left, in the left. So during the operation, we just to remove the tumor, but when we remove all the tumor, we should to the surrounding nearly maybe 2 or 3 millimeters, we should to remove, or sometimes we should to coagulation of the around the wall of the cavernous sinus and the around the pituitary. And now, such as these cases, we remove the tumor, and maybe it's a surrounding of the tumor. So these cases, we can see we peritumor, it's a normal, no find tumor. But these cases, the USP-S8, it's a mutation, and the pathology indicated the ACTH positive, and the TPIT also is a positive. So all these cases after the first operation, and gave the remission, the serum free cortisone is low, it's okay. So that's for the second, if the it's a giant, it's a cases are also the mental irregular 1 years, and then the cases have the patient express moon phase, queuing, and gain weight. And the local hospital, its prolactin level is high, and MRI scan indicated the large tumor. And also this patient have ACTH level, and also the urine free cortisone level is high. And then this patient came to our hospital, or before the operation, we give the PRL, the test. Also, this test indicate the prolactin number. And on the other hand, we also give the patient to the low dose and high dose dexamethasone suppressed test. Also, we can see here the high dose dexamethasone suppressed test is positive. And then we give the patient to the TDAVP exciting test, also indicated the positive. And then these cases we give the bilateral petrol sinus sampling, also indicate we can see also the lateral left or right also very high, but during the sampling, the TDAVP exciting can indicate the the right side is more high. So this patient, we can suggest a large tumor, and we can see here, we open the just under the endoscope. Yeah, okay, we were fast, and to open the cellar and to remove the tumor. Also, okay, yeah. And this case is after the operation, the first day, the cortisol level is also low, and the urine normal ACTH level, and also the prolactin level is normal. And the pathology indicate this case is the double hormone, the ACTH level also positive, and the TPT also positive, and prolactin level that also is it's positive. So the cases is the double hormone the tumor. So during the operation, we total remove the tumor. It's okay, yeah. Okay, we were fast. Okay, just the operation that during the we were to repair the cellar. Okay, and to saturate the duro. Also, it's a patient get a good remission, and it's another cases. It's a giant. They came to our hospital just the dizziness and the vomiting. And before the operation, this patient, the blood serum free cortisol is very high, ACTH level also very high. But the low dose dexamethasone suppressed test negative because the patient, the large tumor and the hydrocephalus. This patient we cannot to give the patient to do the high dose dexamethasone suppressed test. So also, before the operation, we give the PET scan of the daughter scan, and the FDG scan also indicate the tumor and the bilateral adrenal the hyperplasia. So we can see this just also under the endoscope to remove the tumor. That during the operation is fast, and then okay. Way to total remove the tumor. Yeah. Okay. Yeah, we were fast. Yeah, because also the tumor is too large, so we should to piece and piece and to open the cellar widely, and then to after the operation, we should to carefully to repair the cellar floor. Yeah. Okay, it's to remove the near the third vertical. And then after the operation, we can see the third vertical and also to total remove the tumor. And in this case, after the operation, the serum free cortisol and ACTH level, and the pathology indicate the crux cell tumor, and tip it the positive. And then we should to repair to the cellar carefully. Also, such as all these cases, it's a large tumor or giant tumor, and indicate the MRI scan can find the tumor. The second question, if the MRI scan cannot find the tumor, and BIPSS shows central and lateralization artifact, such as this case, we can to see it's a female, 58 years, and express the Cushing syndrome, and also we can see that. Yeah, it's a endocrinology evaluation indicate Yeah, and the MRI scan can just empty cell, cannot find the tumor, but the BI-PSS also shows right, it's dominant. So during the operation, we just to open this to explore the right side. Okay, yeah, just you can see to open and then to push the pituitary, and then yeah, from here we can just can see, yeah, we find the tumor, and yeah, okay, it's very important according to the BI-PSS to find the tumor. After the operation, this patient or get the remission criteria. And on the other hand, for our neurosurgeon, it's very difficult. The third situation, MRI scan cannot find the tumor, and the BI-PSS also have the central dominance, but the dexamethasone, high-dose dexamethasone indicate the positive, and cannot find the others cause the hypercortisonism, such as these cases, 48 female years, the BIPS negative and ACTH, but the high dose is positive. Yeah, we can see. For this situation, we should to explore bilateral. Yeah, we can see. Yeah, just can you see the MRI scan? It's a normal. And during the operation, we first to explore the right side just and cannot find the tumor, and then to explore the left side. But during all this, during the operation to explore, we should to see the wall of the cameral sinus. It's very important for us. And then if the bilateral to explore wished to preserve the middle, it's very important for maintain the partial the pituitary function. Okay, such as these cases, also we have the bilateral to explore and to repair the cell, and after the operation, also this patient get the remission criteria. So, but for the Cushing disease during the operation, the perioperative management is also very important. So we should to, after the operation, to monitor 24 hours urine volume, electrolyte, and monitor the heart rate, blood flow, and also to others such as the hypophyseal function. And after the operation, in our department, we not give the patient to replacement of the cortisone. So also it's very important the perioperative management. So in our department, the criteria, the remission we use, after the first or second operation, the later serum cortisone, the serum-free cortisone less than 5, and then others such as the symptom or disappear, and then no additional therapy at all. So according to this criteria, our remission rate is 87%. So it's from 2003 and from 2003 to 2022. All this is our the remission rate. Now, all in 7 years, the remission rate we get the more than 90%. Maybe indicate we indicated for the Cushing disease we learned the code. Or first it's very low, and then they're nearly 80%. Now we get the 90%. So all these cases we should give the patient the long-term follow-up. such as from 3 months, the more than 10 years, the remission rate nearly 70%. All these cases, we should do the long-term follow-up. It's very important. So, and during all these cases, for the Cushing disease, we have the nearly 1.97% that this patient have the death rate, the nearly 2%. Yeah, 6 cases was died or with the remission cases, and 3 reoperation. The first one is the suicide, and the others embolization of the cardiopulmonary and the leakage infection and others. So for the Cushing disease, we should pay more attention, especially for the perioperative the management. Now, recent 5 years, we have no days. So during the follow-up, we have find the interesting results. We have the 23 cases get the delay remission. It's a immediately remission, and it's a delay remission. The maybe the 60.3%. Maybe why? Maybe we should do some long-term follow-up. And on the other hand, we should do the value of the BIPSS. Now, in these cases, in our group, we have the 402 cases to do, and the remission rate nearly 90%. The negative maybe 77.4%. This maybe BIPSS can increase the remission rate. And on the other hand, the BIPSS match the MRI scan. Yeah, maybe BIPSS, for example, BIPSS indicated the right side dominant, and also MRI scan can find the right side of the tumor is just only 50%. And then match the pathology, just nearly 63. And it's the literature also report. So the BIPSS is gold diagnosis standard of the Cushing disease. But if the negative, we should during the operation to explore bilaterally. So it's very easy. So the 5 results for if a patient after the first surgery, the immediate remission and then recurrence. And then after the first surgery, this patient have the don't get the remission criteria or the persistent. Maybe during the operation, it's a new tumor, or maybe we cannot find a tumor. So the diagnosis is not correct. I mean, all others tumor adenoma totally unresected. So for such a these cases, how to do? Yeah, we sometimes to do the repeat surgery, such as if the patient to do the repeated surgery, the endocrinology evaluate is very important. So we call according to the syndrome and our science, and the urine or serum cortisone, and high dose or low dose, and the BIPS and the pituitary also is very important. So if according to our follow-up, some cases maybe get the delay remission. So we suggest if the patient want to do the second surgery, we should to give the patient to wait for half a year, and MRI scan or BIPS not to effect over the second surgery. So the strategy of the repeat surgery maybe it's difficult to the first. So we should to wide exposing cellular flow, wide to repair repairing cellular flow carefully, such as if no tumor or bypass according to all these. During our cases, we have the 61 cases for the second operation. It's a persistent 29, recurrence it's a 30, and between the first and the second operation, the duration and it's female and the age and the MRI scan match the first MRI scan is just only 20 cases. And the high-dose dexamethasone suppressed the positive 85%. And all these cases, we have the BIPSS 34 and 3 negative and 1 against the first operating. So now we can see our results. Recurrence 30 cases and the remission rate the 83. But for the persistent cases 29, the remission rate nearly 70%. So we repair after the second operation, or the remission rate 72, but same period our remission rate the 87%. So we compare the neuroendoscope and the microscope. So here it's endoscope and a microscope, and the female and the age and the MRI scan. All these cases indicate the neuroendoscope can increase the remission rate compare the microscope. But on the other hand, the complications not high, including the mortality, the CSF leakage, and hyperpituitary also it's a symbol. And during our cases, we should to summarize the children and adolescent Cushing disease. It's different from the adult. So during the period, we have the 26 cases, and because of 4 cases not to follow up, just we summarize 22 cases. But for the children or the adolescent, the Cushing disease sometimes may be difficult because of the sphenoid sinus dysplasia or intraoperative bleeding, because we should to control, especially for the intraoperative bleeding. So we summarize the adults and the or the same period, the male and the female. We can see the pediatric, the male and the female just the equal, and the age and the history and the MRI scan and the BIPSS. All these cases, we for the children, we the positive also nearly 90%, more than 90%, and hybridized dexamethasone suppressed, and remission rate is similar to the adult and the posology. So compare just the male and the female is equal, and also the results similar to the result to the adult. But we should to do for the children or adolescents, we should to control the bleeding, because of the age. Now we will to share some special cases. It's a female, 39 years old, Cushingnoid, and with high blood pressure and diabetes, and low dose and high dose negative. And the BIPS can show the central and the right. The cellular MRI scan can show here it's a micro tumor. So in 2020, we gave the patient for the first operation. The pathology indicate the ACTH positive. After the operation, this patient get the remission, the serum free cortisone and ACTH level also it's a good results. Now this patient to the follow-up, that it's before operation and after the operation, 1 month, 3 months, 6 months, and 1 year. Also, it's okay. We give the patient the cortisone replacement. And after the operation, 1.5 years, and we can find this the serum cortisone as cortisone high. So we stop the replacement of the cortisone. So after 2 years later, this patient to go to our endocrinologist to evaluate. This time the cortisone also high, ACTH also high, the urine and high dose dexamethasone suppressed test positive. So we give the patient for the second operation, but this time maybe we cannot find the tumor, just the normal tissue. So after the second operation, also this patient to the follow-up. The first before operation, after the operation also it's okay. 1 month, 3 months, 6 year, 6 months, 1 year, 2 year, also it's okay. And the second operation, 3 years later, this patient have the recurrence syndrome and also stopping the replacement. And then to go to our endocrinology test, the department, the cortisone and low dose, high dose, and but this time maybe the DDAVP also positive, and give the BIPSS also the right side, the dominant. So we can see here, it's before the third operation, we can see here, maybe the tumor. Now we can, this time we under the endoscope, because the BIPS also indicate the right dominant, and MRI scan also here, the tumor. This time we just to open the wide to expose the right side and not to do others. And we can see here, we can find the tumor. Yeah. But during the operation, maybe the camera centers, the bleeding, we should to control. Yeah. Okay. Now we can find the tumor and to remove after the operation. And after the total remove the tumor, we should to coagulate around the wall, or including the camera centers, the inner wall. Okay. This time, we after the operation, this patient get the remission, get a good results. And also it's another case is it's 18 years with a high blood pressure 2 years, and it have the typical Cushing syndrome, the ACTH level and for cortisol level, and the urine, and low dose dexamethasone and high dose dexamethasone. And now we give the patient to do the DDAVP exciting, and can you see it positive? And the BIPSS also is central, but no lateral side, low dominant, also right side, and the left side also very high. But during the operation, we give the during the sample, we give the DDAVP exciting. Can you see here that it's a right side and it's a left side? Can you see during the after the DDAVP exciting, can find the left side is the dominant. So we can see here it's a tumor left side. Now under the endoscope, we just to remove the tumor, not to preserve the others, the pituitary. We can just open just to separate the pseudocapsula to separate the tumor. Yeah. During the operation, we should to separate the to the boundary of the normal pituitary and the tumor. Now we remove the tumor. Yes. Okay, yeah, okay, so after the remove the tumor, you can see the very near the inner of the camera side of the left. So after the operation, we should to remove to explore the left side of the camera sinus, the inner wall. Yeah, here you can see, yeah, to remove the tumor and coagulate. Yeah, to sometimes we should to resect to remove the inner wall sometimes. Yeah. Okay, to resect the inner wall. Okay. Yeah, after the operation, this patient have the immediately remission, and the pathology indicated TPIT and the ACTH level also the positive. And after the endocrinology test, just others is is normal. Others such as the thyroid and the prolactin and ARH or FS also is normal. The pathology indicate that we can see these cases the inner of the camera sinus cannot see a little tumor cells. So for these cases, such a situation, sometimes we should to resect the inner wall of the cavernous sinus. Now, this case can find the tumor. Yeah, it's another cases. It's male, 11 years, can also Cushingnoid, and the growth reduction and the Cushingnoid syndrome and the ACTH level, protecting the blood-free cortisol level and the urine also, and the low dose dexamethasone suppressed test and high dose is a positive. This patient we give the petrol side also indicate the right side is very high. Can you see the tumor in the middle side? Yeah, it's a children. So during the operation, we to coagulate during to preserve and to control the bleeding as soon as possible. So just we remove the tumor. Yeah. After the operation, also this patient get the remission criteria. This is the pathology indicate the positive of the ACTH and the TPIT. But this case is the surrounding the tumor indicate little the tumor can find. So indicate also get the immediate remission and then the pathology TPIT and ACTH, and others also is thyroid, such as the thyroid also is normal. Now we will introduce the special cases for the, as we know, for the Cushing disease, the diagnosis such as the hybridized dexamethasone suppressed test and BIPSS, it's very important to diagnosis of the Cushing. Such as these cases, it's a male 41 years, first 2003 Cushing syndrome, and low dose and high dose dexamethasone, including DDAVP, also negative. Yeah, maybe at that time we doubt the ectopic, give the patient the medicine, and then the symptom and the syndrome also aggravate. So we give the patient to the left adrenalectomy, and but the symptom also continue increase. Now we can see here that during the operation, just only the MRI scan, the first cannot find something, and then during the follow-up, we can find the tumor become large, maybe caused by the one side adrenalectomy. So these cases, how to treat? Give the medicine, and maybe have the haptic disturbance cannot do, and others the adrenalectomy. So according to the cases during the follow-up, the MRI scan can see the tumor maybe become large. So we give the patient to the transformoid surgery, and it's bypass negative. And after the surgery, this patient get a remission. But it's very important before for such the special cases, we should to MDT multiple disciplinary team to have a discussion. It's very important. And also it's special cases of a cycling Cushing syndrome. It's a female, 38 years. Yeah, 2017 have the Cushing syndrome, and in the local hospital also have the maybe low dose dexamethasone suppressed test negative. And then to our hospital, in outpatient, the free cortisone very high. And then come to the ward. It's very serious. It's very serious. It's very interesting. Can find the ACTH level, blood, the serum cortisone, and the urine. Also, it's normal. Why? This patient, and during this period, the serum cortisone level and the urine and also TH, it's from the wide different. So we during also on the other hand, during this time, the patient, the symptom sometimes improvement or volatile, or including the blood, the serum cortisone, and also TH level. How to diagnosis or how to define where the Cushing, the hypercortisolism. So we give the patient to stay the ward a long time, and we it's very fortunately we can find this patient can the 3 peak and the 3 value. Yeah, here it's very interesting. And now we give the patient to the test such as the dexamethasone suppressed, low dose and high dose, and also give the patient the BIPSS at the peak level, and also indicate that the patient diagnosis the cortisone, hypercortisone from the pituitary. Now we give the patient to the surgery, and after the surgery, this patient get a remission rate. So it's very important. The endocrinology is to evaluate is very important. And the third, also we find the double hormone pituitary prolactin and the ACTH level. And 80 years ago, this patient in the local hospital just amenorrhea, lactation, and the prolactin level is very high. And in local hospital for the TSA transformer surgery, after the operation, the symptom disappear and the prolactin level and normal. And then 80 years later, this patient experienced the high blood pressure, gain weight, and the cortisone level high, ACTH high, and then to another local hospital, give the patient to the low dose and high dose dexamethasone suppressed test, indicate the high dose is positive. And then this patient to our hospital, we give the patient for the low dose and high dose, and also the BIPSS also indicate the patient express the Cushing disease. Now we give the patient to the operation also for get the criteria. Now we to analyze the local hospital's pathology, we can find the tumor and the TPIT also is positive, and then the local hospital, the pathology indicate prolactin also positive, ACTH positive, and PIT1 positive, and TPIT positive. These cases, it's typical double hormone pituitary express the ACTH and the prolactin level. So after this time after the operation, just express the TPIT, no prolactin is negative. Yeah, it's very interesting. So these cases, we should give them more follow-up. Now after operation, it's okay and get our criteria remission rate. And as we know, the Cushing disease, the first choice is the surgery, and maybe others such as the medicine or gamma knife also have the supplement treatment, such as these cases. It's a female, 28 years, just the Cushing syndrome, and ACTH level, urine cortisol level also high, and before the operation, dexamethasone suppressed test is high, it's positive. We can see the first operation here near the cameras, it's the tumor. Just this before the first operation, the tumor can see the positive ACTH is positive, but indicated the proliferative index is high. Now we can to see the patient the follow-up. Yeah, after the 1 week, the after the operation, the prolactin level, the free cortisone is 9, nearly 9, and 1 month it's to get our remission criteria. This time we give the patient a replacement, and 2 months later, the cortisone, the serum cortisone is high, ACTH also high, we stop. And then 5 months later, we give the patient to the endocrinology evaluate, high dose dexamethasone positive, and the BIPSS also right side. We can see the MRI scan can show also the tumor around the carotid. So for the second operation, it's very difficult. So we MDT discussion indicate this patient for the second operation is difficult, so suggest this patient to do the gamma knife. So this patient for 6 months later, the patient to gamma knife. Gamma knife 10 months later, it's very good, get the remission. So during the follow-up, this patient is very, now this year, have the auxiliary pregnancy and get to have a son. So sometimes we should to do the patient to the multiple choice. Now, we will conclusion. The Cushing disease diagnosis sometimes is very difficult. So according to the syndrome and the science and the endocrinology evaluations, such as low dose and high dose, BIPSS and imaging. So all this, it's very important. And then the second, BIPSS, it's a golden standard diagnosis, but to define the source of the ACTH, but unclear to localize the tumor site. Maybe it's not correct. So the third, post day, the first day or second day, to evaluate the the remission, to evaluate the earlier remission. So for the persistent cases, follow-up may to 6 months at least. repeated surgery for the persistent or recurrence cases. So before all these cases, endocrinologist evaluation is very important. So during the surgery or during the treatment, how to balance the remission and hypopituitarism, yeah, such as the remission or hypo. So we should to discuss with the endocrinologist to repair the pituitary. So such as for treatment, so we should to give the patient to have a good results and let the patient to return to the family or to the society, such as these cases. It's before the operation, the patient is at 270 kilometers, and so the before operation and during the operation and after operation, this patient stay in the ICU, and then so this patient get a good remission, and after operation, this patient to society and have the good life. So for the Cushing disease, so we should to give the patient to return the family and the society. Now, the last, we will acknowledge our pituitary diagnosis team, craniology team, and the surgical team, including the intraoperative nurses and our ward nurses and accessory teams. And also we should to special thanks our patient we have some experiences. Okay, thank you very much.
Any question from you, Ben?
Yes, can you hear me? And yeah, thank you for Professor. Your center is very famous around us as in Hong Kong for the handling pituitary surgery, and really congratulate on your results on managing the Cushing disease. And it's a quite a difficult situation as to manage, and we also encounter those special cases as shared by you. Those are very difficult cases, and I echo that the multidisciplinary approach is very important to handle this. Some question about your presentation. So the first one is about those recurrent cases. How do you select those cases for reoperation versus radial surgery? So in the center, how would you choose between two for the recurrent cases? So my second question is about for those patients with repeated operations, or those medical or those workup negative cases, would you consider giving the medical therapy instead of exploration surgery for those medical workup negative cases? And yeah, thank you so much, Professor.
Okay, yeah, thanks. Your good question. Yeah, for the recurrence or the repeated surgery, all these cases, before we have the decision, we should have the discussion with our team. The common knife or radial surgery, and then our tear transphenoid. So we just all these cases, we have the results indicate the recurrence. For the recurrence, the repeated surgery have the good results, nearly nearly 70%. It's good results. Yeah, but for the persistent, the second surgery, the result is not good. So in our team, if our patient is a recurrence, we will recur the first diagnosis, recur the video of the first operation. Yeah, according all this, and we were to define this patient to do the second operation. Yeah, and then for the radiosurgery, yeah, maybe in the literature they have sometimes they have the good results, but the radiosurgery can cause the hypopituitarium have a long time. So in our center, with the choice, maybe the third choice. First, yeah, if after the recurrence, which first we choose the second operation, and then for the gamma knife or the radiosurgery. That is the first question. And then the second question, the medical therapy. Yeah, as we know, the many new medicine tend to treat the Cushing disease, such as the parasite and others. But in mainland, many medicine cannot get. Yeah. So we sometimes we suggest the patient to Hong Kong to get the medicine. Yeah, usually such as the Cadison, maybe to or Thailand or Hong Kong to get the medicine. Yeah. So
Yes.
for the medical treatment, because of the medicine cannot easy to get. Yeah. So for the Cushing syndrome or Cushing disease, the first operation, radiotherapy and medical, and maybe for the difficult cases, maybe to the bilateral adrenal ectomy also is a choice. Yeah.
I see. And really, thank you so much. And I just have another quick question about for your in your case series of those ACTH positive tumor. So usually the behavior should be more aggressive and more prone to recurrence for those ACTH stain positive. Is it the case in your series compared to other pituitary adenoma? So the ACTH stain has a more recurrence and more aggressive in your case series.
Yeah, but because firstly we do the Cushing disease surgery, the remission rate is not high, just 25%. Because we want to just to remove the tumor, maybe as you just said, ACTH positive level maybe have the aggressive. So during our experience, we now, if the MRI scan can find that the tumor is the boundary is clear, during this time we remove the tumor, we should to coagulate or remove the 1 millimeter surrounding the tumor. Yeah, sometimes we can find the surrounding the tumor, the pathology, even if the pathology indicate the no tumor, but the ACTH the positive is the positive than the other tissues. So for the Cushing disease, we should to remove around the boundary. And sometimes if the Cushing disease near the cameral sinus, we should to resect the cameral inner wall of the cameral sinus. So during the operation, maybe aggressive than other tumors such as acromegaly or prolactinoma and others. Yeah. Yes.
I see.
Yeah.
Thank you so much.
Yeah. Thank you.
I don't see any other question. Thank you again, Professor, for very comprehensive lecture. And I see your lecture covers almost every question that I want to ask. And it's an excellent presentation. And I think the management is very comprehensive too for all your patients, and congratulations for your excellent commitment in cases of very difficult cases. So I think we come to the end of today's webinar. On behalf of the Education Committee of the ACNS and the President, Professor Joko Kato, I would like to thank both speakers today, Professor Anita Jegetia and also Professor Liao Guanbian, and as well as our chair, Professor Paritosh Pendi, and the time and support for the ACNS webinar. A special thank to Professor Zubin for broadcasting this webinar on the WeChat channel. And also a special thank to both my co-hosts here, Dr. Ben and Dr. Joe, for joining us today here. And so until we meet again next Saturday, is bye-bye from all us. So thank you very much. Thank you, Professor. Good night, everybody. Bye-bye.